Welcome, everybody, for Dr. Robert Fisher's session in the new definition and classification of epilepsy, who has epilepsy and what type of seizure. It is my pleasure to introduce Dr. Fisher. He is the director of the Stanford Epilepsy Center, and also he's the past president of the American Epilepsy Society and past editor-in-chief of epilepsy.com. He led the International Committee to define and classify seizures, the subject of his talk today. So without further ado, I'd like to introduce Dr. Fisher. Oh, Dr. Fisher, you're on mute.
Thank you, Beth. This is a picture from the previous years when we really were in person in Disneyland, and I hope those days will soon come again. I was given a committee job by the International League Against Epilepsy, which is the overseer of all the scientific societies about epilepsy in the world, such as the American Epilepsy Society, to get consensus on the definition of epilepsy, who has it and who doesn't have it, and also to update the seizure classification, which was confusing to many people. Not everybody likes renaming things. They find it effortful. I've just come out of the witness protection program after that little committee task, but I will share the update on the classification and also on the new definition of epilepsy. I have some disclosures that I put on slides, but none of them are relevant to this talk, so I will move on. It's interesting to consider the history of famous people who have supposedly had seizures over the years. Of course, some of these were a few thousand years ago and we can't be certain, but high likelihood that many world leaders, people in the arts, entertainers, and athletes have had seizures. I could spend the entire segment of the talk talking about this, and it would be interesting to do. But I just show it to make the point that despite how epilepsy is devastating to the quality of life, it is possible to achieve greatness with epilepsy, at least in some circumstances. So what we'll talk about today is what is a seizure, what is epilepsy and who has it, and what are the types of seizures. Let me just quiet a bit of the background noise and I'll be right back.
Hi, everyone. Thank you for your patience. And please feel free to put any questions you might have into the chat box, and I'll be monitoring that.
Okay, thank you. Hopefully quieted some of the background noise. So speaking of background, let me just do a little bit of general background here before getting specific. So a seizure is the event. Epilepsy is the condition of spontaneously recurring seizures. And the official definition of a seizure is a transient occurrence of signs or symptoms due to an abnormal, excessive, or synchronous neuronal activity in the brain. And that's a bit of a technical definition, which may be hard to understand, but the short version is a seizure is an electrical storm in the brain. Here's an example. You have normal EEG, normal brainwave patterns here. You then have a flattening of the EEG activity for a few seconds. This is 20 seconds on this whole page, kind of the calm before the storm, if you will. And then you see the high voltage synchronous electrical activity that occurs as the person is stiffening and jerking in a tonic-clonic seizure. So let's move on to what is epilepsy and who has it. Epilepsy is very common. You know this. It's more common than most people realize because it's not obvious that a person has epilepsy unless someone is observing them have a seizure, but it is the most prevalent serious neurological illness that can affect people of all ages. Many people think of it as a childhood disease, but it actually peaks in the young and the old. And of course, people can have it through their lifespan. If you're fortunate enough to live to be 75, and I hope you all will, you have a 10% chance of having a seizure. For the fortunate two-thirds with epilepsy, it can be controlled fairly simply with medicines, and people do fine, live their lives quite well. But the one-third for whom the medicines don't control have a very hard time with the epilepsy, and it seriously affects their quality of life. And this number, by the way, the one-third that's uncontrolled, of 1.2% of the world's population, about 3.4 million in the US. This number of uncontrolled people with epilepsy is larger than all people with brain tumors, larger than all people with multiple sclerosis, larger than all people with muscular dystrophy. So even though the majority of epilepsy patients can be controlled, it's far from being a solved problem. We think about the causes of epilepsy in two big baskets. One of them is genetic, and the other one is acquired. With genetic epilepsy, this is a pair of twins in a famous twin study, because if you're an identical twin with generalized epilepsy, your other twin has about a 60 to 70% chance of also having the same type of epilepsy. The EEG shows spike waves in absence, or what used to be called penile epilepsy. There are different types of genetic uh, factors. There are dominant genes, which means that if one of your parents has that type of epilepsy, you will get it. There are recessive genes where both parents have to have it. There are X-linked genes, which are passed through the mother. And then the biggest category is susceptibility genes, genes that make you more prone to have a seizure if something else happens in your life. So two guys may fall off a motorcycle without a helmet, and only one of them ends up having epilepsy because the person who ends up with epilepsy has other genes that make the head trauma more serious. So speaking of head trauma, that would be an acquired factor. Here's an example. Here's a blood clot outside pressing on the brain called a hematoma for trauma, and that would injure the brain cells underneath. Now, why would that lead to epilepsy? Well, the thinking is that, in a simple cartoon way, the brain cells or their axons, which are the output wires from the neurons, are injured, and therefore nearby brain cells sprout other connections, sprout axons to fill the empty spaces, just like a weed in a garden would do that if you pulled out the plants, or vice versa, with the plants and the weeds. So as that connection happens, you have more neurons wired together. It's a bigger network, so that when one neuron fires, it's now talking to more neurons, and a lot of them fire. And this leads to a higher level of firing, which spreads more and can lead to seizures. That's also probably why there's often a delay after an injury. Even a birth defect may not show up until the teens or the 20s. So the traditional epilepsy definition was two or more unprovoked seizures, not on the same day. So what does unprovoked mean? If if you had an immediate thing that caused the seizure right then and there, it wasn't considered epilepsy. It was called a provoked seizure or an acute symptomatic seizure. Example would be a febrile seizure in children prior to the age of 6 years old. They don't hardly occur after that. And that's the most common cause of seizures in the world, actually, but it's not epilepsy. Alcohol withdrawal seizures, metabolic seizures from your electrolytes getting out of whack, toxic seizures from drug reactions or withdrawal, seizures where the big football player faints in the blood lab because of the sight of his own blood being drawn, or seizures within the immediate time of having brain trauma or a meningitis or a stroke. All of those things are not epilepsy unless the seizures start coming back on their own. Recurrent, unprovoked seizures. So, this is a pretty good definition and it applies most of the time, but it had some problems that caused us to tweak it a bit. The first, these are the two big ones, not the only ones, but the first major one is that some people will have one seizure and they will have a very high likelihood, by which I mean more than 50-50, of having another seizure. And if that person walks into a doctor's office or a doctor who deals with epilepsy, um, we just think there's a high chance there's going to be another seizure. So we want to offer that person anti-seizure medication to try to prevent that seizure. And so we're thinking of that person as having epilepsy, a condition of recurrent epileptic seizures. The other problem with the old definition is that it did not allow outgrowing epilepsy. You could have an 85-year-old man who had a seizure at age 6 and another at age 8, no medicine since age 10, no seizures since then, but still was said to have epilepsy. So we made a revision of the definition, and there's both a conceptual and a practical aspect to this. So let me give each of those. The concept is that epilepsy is a disorder of the brain characterized by an enduring predisposition to generate epileptic seizures and by the neurobiologic, cognitive, psychological, and social consequences of this condition. Get rid of that, whatever it is. This part is very important because those of you who live with epilepsy or live with someone who has epilepsy know that um, these psychosocial consequences are in many cases more of an issue, more of a problem than the seizure itself. Now, this is a concept, but it isn't really specific enough to tell whether someone has epilepsy or not, except in general. So a few years later, we made it more specific, defining epilepsy as a disease of the brain defined by any of the following: at least two unprovoked or reflex, that means, for example, in response to flashing lights, seizures occurring greater than 24 hours apart. That's the old definition. It still works. But you also might have epilepsy if you've had only one seizure and you have a high probability of having a further seizure. And if anybody wants in the questions, I'll go into why we picked that number, but otherwise I will skip over it. I'll also skip over epilepsy syndromes for the moment. But then in the other direction, epilepsy is considered to be resolved. We don't say cured, we said resolved for individuals who had an age-dependent epilepsy syndrome that always gets outgrown, or who have remained seizure-free for the last 10 years with no seizure medications for the last 5 years. What does that mean? Well, it doesn't mean that you have a guarantee that you'll never have a seizure again. It could relapse, but it means the chances are small, and that officially, say if somebody asks you on a insurance form or a driving form, do you have epilepsy? And you haven't had a seizure for 10 years, and you've been off seizure medicines for at least 5, you don't have to say that you have epilepsy at that point. So hypothetical cases. A 25-year-old woman has 2 unprovoked seizures about 1 month apart. Does she have epilepsy? Yes, she does, according to both the old and the new definition. Another hypothetical case. A 40-year-old man had a focal seizure with left hand twitching that progressed to atonic, stiffening, and clonic jerking seizure. This was his only seizure in his life. MRI shows a probable tumor in the region of the right temporal lobe. MRI always reverses left and right. And the EEG shows epileptic spikes in that area. Now, this guy has only had one seizure, but every epilepsy doctor I know is going to put this person on medication because he has more than a 50-50 chance um, of having another seizure. So he would have epilepsy by the new definition, but not by the old definition. Here's a point of some controversy that the International League faced, which is whether to call epilepsy a disease or a disorder. And by the way, this wasn't my choice. This came down from the uh, uh, league's board. Um, a seizure disorder would be an accurate term. Some people like to say, I have a seizure disorder and not I have epilepsy. That's accurate if you've had a provoked seizure or if you have a single seizure with a low chance of having another one. Um, Disease, the word has more stigma, and some people who are kind of ignorant, but there are many in the world, mistakenly think that a disease like epilepsy can be contagious because it's called a disease. The problem that the league thought was that the word disorder just did not convey seriousness of epilepsy. You have heart disease, you have kidney disease, you don't have a heart disorder, you have heart disease. Cancer is a that's a typo. Cancer is not a disorder. I'll correct it right now. It's a disease. So a disorder doesn't get much research or philanthropic funding. For these reasons, the board of ILE declared that epilepsy should be called a disease and not a disorder, and we can take questions and comments from people who may disagree with that. So the consequences of a new definition have both good and bad aspects. One is it's the good thing, it's closer to how the clinicians view epilepsy, which is what a definition should do. It helps reimbursement. If you can say someone has epilepsy and you want to treat them even after a single seizure, more likely that you get the medications paid by insurance. There's support for an earlier diagnosis, which would allow more disease modifying therapy to prevent that second or future seizures. And it also allows for people to outgrow epilepsy, with epilepsy being no longer present. The aspects that are not so good, it may upset those who are diagnosed sooner, may increase stigma, which may restrict some activities. We talk about if there's more than a 50-50 chance of recurrence. The number is actually 60%, but I'll round it to 50-50. But the data in a number of circumstances is not there to really know what the chances are of another seizure. And in that case, you revert to the old definition of having to wait for a second unprovoked seizure to occur. And overall, it makes diagnosis more complicated. But this is the kind of thing that we all hope for when we doctors dedicate our life to treating people with epilepsy. Dear Dr. Fisher, 10 years seizure free. Thank you for a life I could not have dreamed possible. This was actually a pilot, and he became seizure free after surgery, was seizure free for 10 years. He was allowed to fly again, not commercial, but in his private planes. I'm sorry, the slides are not always advancing. Um, but this is what we wait for. All right, so let's move on to the third part of the talk. What are the types of seizures? The kind of seizures that people have depend upon a lot of things. Their age tend to be different in young children, whether they happen when you're awake or asleep or both, what type of seizure medication you're on, whether you have a brain injury of some sort that's causing the seizure. But a very big part of what causes a seizure type is where the seizures start in the brain. Your brain is laid out with functions in different areas. There's a motor strip. There's a skin sensation strip right behind it. There's areas for talking, Broca's area, for hearing, and for understanding speech, Wernicke's area. There's a vision area in the occipital lobe, the back of the brain. And then there's the deep structures to the temporal lobes on the side of the head, where the amygdala has a lot to do with emotions, and the hippocampus has a lot to do with memory. So if you have a seizure, for example, up here, your leg is going to jerk. Here, your fingers might jerk. Here, you might feel tingling in your fingers at the start of a seizure. Here, you might not be able to speak. Here, you might not be able to understand. Here, vision, what you see will be distorted. And if it happens in the hippocampus, you will not be able to lay down memory traces for longer than a few seconds at a time. So the world will become very disjointed and confusing. So this is the underlying part of physiology that causes seizures. Sometimes we need to do recordings in the epilepsy monitoring unit, video EEG recordings, to clarify where in the brain seizures do occur, both by EEG recording and by watching which part of the body is involved first. So let me talk about classification of seizures, and I'll show you two old classifications briefly and then tell you why we now have a new one. If you're old enough to have had seizures in the 1950s, they would have been classified with these words: focal seizures, psychomotor seizures, petit mal, or grand mal. Focal seizures are moving or sensation in one part of the body. Psychomotor seizures, which then became temporal lobe epilepsy seizures, then complex partial seizures, and now focal impaired awareness seizures. Psychomotor seizures were staring, fumbling, forgetting. Petit mal was brief staring, eye fluttering, usually in children. Grand mal was sudden loss of consciousness, falling to the ground, stiffening, and jerking. So that was revised in 1981 by a group of doctors. I was not old enough to be on that group then, um, that looked at many videos, video EEGs of different seizures and classified them into a group. And they divided them into partial seizures, which we've renamed focal for greater clarity, which start in one half of the brain, versus generalized seizures that appeared to start on both sides of the brain all over, or those that they couldn't classify. And the partial seizures were either simple partial, meaning that there was no loss of consciousness or memory. The person knew everything. Maybe it was just hand twitching or a deja vu sense. Um, Complex partial seizures, memory and consciousness were impaired. Secondarily generalized would start in one place, so they could be simple or complex, but then become tonic-clonic. So that was the partial seizure group, and then the generalized seizure group was absence, the old petit mal, tonic-clonic, which was the old grand mal, atonic, which are epileptic drop attacks, myoclonic, which are brief, uncoordinated jerks, or some other or unclassifiable seizure types. Now, that classification actually worked pretty well, and it's the one that most doctors know these days. And I think it's still the one that most patients would use, although some still refer to petit mal and grand mal. And by the way, some patients talk about petit mal as any small seizure and grand mal as any big seizure. And when I hear that, I always try to understand better what that means, because it may just be that they're all what in this classification would be called complex partial seizures, but some are just bigger than others. So the problems with the old 1981 seizure classification were these. Some seizure types, for example, tonic seizures with stiffening or epileptic spasms, which are usually under 1-year-old children. The seizure looks like this. So those could be either focal or generalized, but in the old classification, they were just generalized. If you didn't know how a seizure started, it was unclassifiable. Even if it was obviously tonic, clonic with jerking, you couldn't classify it. It was difficult to know by history, which is how we diagnose most seizure types and epilepsy. Difficult to assess consciousness retroactively, whether a person was or was not conscious. And then some terms in use, I list them here, didn't have a lot of understanding among the public or even doctors. Less than 50% of people in one study classified their seizure type according to the same type their doctors were classifying it. I'm not saying which were right or which were wrong, but that's a pretty high level of disagreement. And then some important seizure types weren't included. So here we have the new classification. This is it in its very simple form. We wanted in the committee to come up with a classification that was based on the underlying science of why seizures happen in the brain. But we couldn't do that because our understanding was just not advanced enough to say, here's why there's a seizure with an absence attack, and here's why there's a seizure with a motor attack. So we did keep the division of focal onset versus generalized onset, but we added a category of unknown onset. And as you get to know more, the seizures in this category might move into either focal or into generalized. So knowing focal onset is important for several reasons. One is something is wrong with that part of the brain. Two, meds differ for focal versus generalized seizures. And three, a person who has focal seizures might be a candidate for surgery or for neurostimulation. Now, don't get intimidated by this slide. This, if you will, this is the neurologist's classification, the expanded version. Everything that you see in blue is the same as it was in the previous slide, but it now has subcategories of different types of motor and non-motor focal seizures, more generalized seizure types, and a few unknown seizure types. So that is the new classification. Probably the important ones to think of is if you previously had simple partial seizures, focal simple partial seizures, meaning you didn't black out with them and you knew everything. That's now a focal aware seizure. If you had a seizure that started in one part of your brain but caused you to lose awareness, that is a focal impaired awareness seizure. The old grand mal is generalized tonic-clonic. The old petit mal is generalized absence. And there are other generalized seizure types. Now, I'd like to point out that any seizure can start in one part of the brain. I should talk about focal seizures in this because the generalized already start all over. Any focal seizure can start in one part of the brain and spread to other parts. Therefore, you might have a person who has focal aware seizures. They start with a tingle in the hand or a feeling of deja vu or of fear, or a rising sensation through their body, cold, hot, stomach upset. Focal onset, but they know everything. So it's focal aware. But then it spreads to the other side of the brain, and now you can't lay down memory traces, and it's become a focal impaired awareness seizure. But then it spreads more. It spreads to the whole brain, including the motor cortex, and you have a tonic-clonic seizure. It didn't start generalized. It started focally. So it's a focal to bilateral tonic-clonic seizure, what used to be called the secondarily generalized seizure. In a way, that's one seizure. It just spread further through the brain, but the classification gives it a different name at each stage. And that's just a practical matter because we cannot name every possible pattern of seizure spread throughout the brain. So we name the components. What medicines do, by the way, in a lot of people is not stop that very focal onset part, but keep it from propagating through the network so it doesn't lead to loss of awareness and it doesn't lead to falling down and shaking, the tonic-clonic activity. You'll notice also that we have the word awareness and impaired awareness here rather than consciousness. Um, Honestly, we really still mean consciousness, but it's just easier to use awareness as a surrogate marker because we ask people during the seizure, maybe you couldn't talk, you couldn't move very well, but did you know everything that was going on? And you could remember after that someone walked into the room during your seizure. They say, yes, I know. Then we know that they're aware. But asking about consciousness is hard. So here are the old and the new terms. Unconscious is still used, but it isn't in the name of the seizure type, is impaired awareness. A partial seizure is a focal seizure, starts in one part of the brain. A simple partial seizure is a focal aware seizure. A complex partial seizure is a focal impaired awareness seizure. In 2011, the word dyscognitive was introduced for complex partial seizures. Almost nobody liked that word, and it's gone away. Um, in 1981, there was a seizure type that was called psychic. That that sounds a little supernatural, so it's now called a cognitive seizure. Secondarily, generalized tonic-clonic is now a focal to bilateral tonic-clonic. Seizure arrest, freeze, pause, interruption is now a behavior arrest seizure. So most of what we did in upgrading the terms was not at all radical. It was just really renaming, clarifying, adding a few new seizure types. The net effect of doing this is that the classification of seizures should make the choice of a seizure type easier for seizures that did not fit into any prior categories. It should clarify what is meant when a seizure is said to be of a particular type. It should provide more transparency of terminology to the non-medical community and should make it more likely that patients, families, and doctors will all use the same terms to classify a seizure. Now, let me show you a practical way of determining what type of seizure you have by answering up to just 5 questions. And I can't offer this to you online yet because it's still being validated, but I can show it to you. It's an interactive patient seizure classification. What do you call your seizure type? Let's call it the shakes. It's your own words. I'll have the computer ask the questions.
Do you have a warning for the seizure coming on? Don't count non-specific anxiety long before the seizure or a sense that a seizure may be coming later in the day.
Let's say yes, we have a
What is
warning.
your warning? Please choose the first thing that happens with a seizure. Don't count non-specific anxiety long before the seizure or a sense that a seizure may be coming later in the day.
So let's say it's a
Choose a
sensation.
sensation from this list.
Let's say it's a skin
At any
sensation.
time during the seizure, do you lose awareness or memory?
Let's say no.
At any time during the seizure, do you stiffen and jerk?
Let's say no.
Focal aware sensory seizure.
So from that answer to those questions, which are summarized here, um, the software knows that your seizure type is a focal aware sensory seizure. The old name was simple partial sensory seizure, and then it gives some information. During a focal aware sensory seizure, this person may experience visions or sounds, sensations on the skin, smells, tastes, or spinning vertigo. These are produced by abnormal electrical activity in the brain and not a real physical perception. When the seizure is focal aware, it implies that awareness of the surroundings is preserved throughout the entire seizure, even if the person may be immobilized and unable to respond. So let's see if we can get some audience input into this. Would anybody else, would anybody online care to either unmute or type in answers to the question? You don't have to identify yourself, but we can see if it works for your seizure type. I heard a sound. Do we have a volunteer? Maybe
No.
No volunteers? Okay, oh, Elizabeth.
Yes.
Yes.
Can you hear me?
Yes, I can. Do you have a warning for the seizure coming on?
No.
What's the first thing that happens? A sensation, a movement, an emotion, freezing or staring, odd thoughts, or other?
Other.
What is your other?
Stuttering.
So this won't be able to class, whenever it's other, there are no branches to classify the nature of your seizure. So the program fails you in this regard. But
Okay.
if let's take it from the way you started, warning, yes. By the way, the reason for write-in is so that I can, if a lot of people are putting stuttering or some particular thing in, I'll change it in the next version of the program. So let's say that stuttering is your speech isn't stuttering, but it stopped completely.
Yeah, that's what happens.
Oh, okay. Do you have staring with eyelid fluttering during your seizure, or any arm jerking?
No.
Just freezing and staring, but no details. At any time during the seizure, do you stiffen and jerk?
No.
Okay, so because the stuttering is not there, it's still an unclassified part of the seizure. So again, I apologize. You have a difficult seizure type to classify.
That's all right. I stutter and then I stop speaking completely.
Yes, so speech. So, and then do you freeze during the whole seizure? Or do you make movements, or just freezing up?
I can move completely. I just can't remember any words. I can answer yes or no.
Mhm.
That's it.
Okay, so this is an aphasic type of seizure,
Hmm.
and I think it's a good thing to put in. So I'm going to add that as a possible choice as well for when this goes online. Does anybody else who has a more common seizure type care to try? As you can see, it's painless. Okay.
So Dr. Fisher, we have a couple of comments and a question. So
Okay.
we have a comment from Kate. She would like a copy of the slides if possible. Thank you.
Sure. Send me an email to my email address, and I will and ask for the slides for the talk. That goes for anyone who's on the talk, and I'll return them to you. My email address is my name, robert.fisher, FISHER @stanford.edu. I'll show that to you in writing.
And then we have another comment from Doris, but myoclonic doesn't always cause unconscious.
Myoclonic doesn't always cause what?
Unconscious.
Yes. Okay. Good observation. So you probably noticed that we divided the focal seizures into aware and impaired awareness, and we didn't do that for the generalized seizures. because they are overwhelmingly with impaired awareness. So we thought it would be pretty small category for generalized onset aware seizures. But there are some where you cannot tell that there's loss of awareness or loss of consciousness because they're so brief. And myoclonic seizures are among those. Um, if you were to have multiple myoclonic jerks in a row and somebody were to do some, flashing word testing or flashing picture in the middle of them, usually people are not going to be 100% on that. But, if there's like just quarter of a second of loss of awareness, it's not going to be noticed. So I think myoclonic seizures is too brief to see any loss of consciousness. Other questions or comments?
Yes, we have two questions from Christopher. Hi, Dr. Fisher. He has two questions. A neurologist at Mayo Clinic told him if he treats his sleep apnea, he might not have seizures. What are your thoughts?
Yeah, it's worthwhile to do. There is a higher incidence of sleep apnea in people with seizures and a higher incidence of seizures in people with sleep apnea. Sometimes it can be pretty serious. With sleep apnea, the oxygen levels can go down. Normal would be like above 95%. Below 80, we worry. And below 70%, it's quite possible that seizures can be precipitated. But sometimes, even with lower levels of oxygen drop from the throat closing off with untreated sleep apnea, seizures can be precipitated. My experience, whenever I hear that someone only has seizures during sleep, I always think, could it be sleep apnea? It isn't always. Sometimes people do just have seizures during sleep. But um, I wish it were the case that treating the sleep apnea usually got rid of the seizures. Usually it helps, but does not completely get rid of them. However, if you have sleep apnea to a significant extent, even apart from seizures, it's important for health to get it treated. Other questions or comments?
Christopher's second question, can seizures change from night to day? His were daytime complex partial with generalized, and now they are only in a sleep and milder. Is it possible to go back?
Sure. So just for interest, the new term would be focal impaired awareness and focal to bilateral tonic-clonic seizures. But don't worry about it. It's going to be 3 years before the world gets used to those new terms and everyone starts using them. Um, I wonder. I wonder if medications had changed at any point, or it sounds like something had changed because there were daytime seizures, and as I understood the comment, there are now nighttime seizures only, and they're milder. So I wonder if it was a medication change. Um, but seizures can occur both waking and sleeping, waking only, sleeping only. And it tends to depend upon the seizure type. So the time of day that's worst chance for having a focal seizure is right around the time of falling asleep with drowsiness and light sleep. The time of day that's worst for having a generalized onset seizure is within an hour before or after waking up in the morning. This is not a 100% thing, but statistically it's been documented in a lot of studies. And either some change in medication or some change in the brain or some change in a person's sleeping pattern can cause seizures to shift from mostly during wakefulness to sleep, and can change the type as well. So Christopher, I'm not sure enough in your case what might have changed to be able to pin that down for you.
So Christine has a question. How do you determine if the seizure is atonic if he has complex partial seizures with secondary generalization and usually always falls in the process? Most times he is upright starting either sitting or standing, then he falls over?
Yeah, that's a good question. A tonic seizure with stiffening or tonic-clonic with stiffening and jerking has a rigid phase. An atonic seizure means loss of tone and the person drops like just a limp rag. They just go down limp and loose. The atonic seizures are also pretty brief, usually lasting just a matter of some seconds. The person's on the ground and they start coming around and they're able to get up, whereas your tonic and tonic-clonic seizures most of the time last more than a minute. But the atonic seizures are limp. You can hurt yourself badly with an atonic seizure. These sometimes require the football helmets for protection. EEG pattern also differs. Other questions?
Yes. So Elizabeth said she actually was diagnosed with hyperexplexia, but she smells things that aren't there, and she has those speech arrests, no EEG signals.
So hyperexplexia is like an excessive startle reaction. It runs in the genes, particularly people of Southern Canadian descent somewhere in their background. Uh, Although not only there, but it's a big part of the gene pool for that. Hyperexplexia is not in itself a seizure. It's an imitator of seizures. I see Elizabeth nodding your head. Is this your condition that you're talking about? Oh, maybe that's why it's hard to classify your seizures. Are we sure they are seizures rather than hyperexplectic attacks?
I know that I have the hyperexplexia attacks. What I'm concerned about is the smelling things and the speech arrests.
Yeah, that I have to admit sounds more like a seizure. So you may have two things going on. I don't know. I have to refrain myself from diagnosing over a Zoom line. It's not really good medicine. So nobody take anything seriously that I'm saying about your individual case here. But I would wonder if there's more than one thing going on from what you described.
So Melissa says a lot of people, doctors refer, say, grand mal to tonic-clonic. Because these classifications are fairly new, how can we all get on the same page of knowing the new seizure names?
Um, well, let's see. You can. I don't know how all of you can do it, but I can certainly send you this lecture. You can go to the site of the International League Against Epilepsy, um, and they have material on this as well. I will try to promulgate more educational materials online for people to use, um, but it will be a continued educational process. It really does take some years before people get used to the new terminology. Before I forget to mention it, I'll take some more questions, but I promised the organizers to plug next year's Epilepsy Awareness Day, which they hope will really be held at Disneyland. I hope by then we'll be able to get together again in person on November 8th, 9th, and 10th, 2021.
So we have several other questions. Christine says, have you heard of seizures that only occur in the first 2 to 3 hours of waking? What causes that?
Yeah. So I wonder if it's a generalized type of seizure, because that's the usual time pattern in the day for generalized seizures that occur relatively soon after waking. In fact, in some people, it's so consistent that they can get a license to safely drive after, say, 11 a.m. The mechanisms of focal and generalized seizures are different, the kinds of synchronization that happens in the brain. And it interacts with sleep because sleep in different stages, drowsiness for one, let's say waking for another, has different brain synchrony patterns during different times of sleep. So if the synchrony pattern from sleep adds together with the same kind of synchrony pattern that could be causing a person's seizures, then that can be bad and that can provoke a seizure at that period of time. Many people's seizures are linked to the sleep wake cycle, more likely at a certain time of day. And we've known for a long time that women's seizures are linked to their hormonal cycle, with most of them having seizures around the time of menstruation, but some having seizures in the middle of the month as well. And now we're learning with long term recordings that we do that everyone, including men, have rhythms of higher probabilities of having seizures that wax and wane in regular waves with a time period often lasting a few months, not monthly, but a few months at a time. And we're using that to try and forecast when people are more likely to have a seizure because maybe that ought not to be the day you go on that long hike, and maybe it's a day you should take an extra medicine.
So Christopher has a comment. I have been on Vimpat for the last 3 years, so medication has not changed much.
Medication has not changed much in the terms of controlling seizures. So if that's the meaning, as opposed to medication does not change much, the medication dose has not changed much. If it isn't controlling the seizures, then first thing to make sure of is that it's at a good dose and a good level. Typical Vimpat dose would be 150 or 200 milligrams twice a day. It usually isn't pushed much higher than that because it can cause heart irregularities if the dose gets too high. Otherwise, it's a very safe medicine. If one medicine doesn't work, my own feeling is don't spend a year wasting time with that, but try another medication. If a second medication doesn't work in an adequate amount, and we got 26 medicines to try, you can't spend your whole life trying them all in combinations. If a second medication hasn't worked, then the chances of a medicine controlling the seizures completely is actually pretty low. At that point, your seizures have declared themselves as being in the 1/3 that is not responding very well to medications. And depending upon how much the seizures are screwing around with your quality of life, you might then want to start thinking about non-medicine treatments. In some cases, particularly kids, you heard in the previous talk, ketogenic diet. Some people may be candidates for epilepsy surgery. And the big new thing is neuromodulation, which is my area of research. And it's what I was originally going to talk about. But then I saw in the program that 3 other people were talking about neuromodulation, and nobody was talking about the new classification. So I switched. But neuromodulation with vagus nerve stimulation, responsive neurostimulation, or deep brain stimulation, um, it's usually not a cure, but it almost always is quite helpful and can sometimes make people seizure free. So I don't know where you are on your trial of medicines. I just heard about Vimpat, but if a couple of seizure medicines haven't controlled seizures adequately, then I recommend being at an epilepsy center where they can consider non-medical treatments for epilepsy. And in a few cases, not yours with the Vimpat, but in a few cases, turns out that the reason the seizures aren't responding is because they're not seizures. They're one of the imitators of epilepsy. And this title of one of my books, Imitators of Epilepsy. And there are like a dozen chapters in there of complicated migraines, transient ischemic attacks, sleep disorders, movement disorders, um, psychological conditions that imitate epilepsy.
So Dr. Fisher, we have several more questions. However, it's 11:54 and the next session is going to be starting at 12. So would you like those people to email you with their questions?
That's fine. And
Okay.
I will give you brief answers. So I had shown you my email address. I'll make it bigger for you.
Thank you so much, everyone, for joining Dr. Fisher's session, and hope you have a great day.
Thank you all for being so attentive and for showing up. 2/3 of life is just showing up.
Thank you, Dr. Fisher.
Farewell.